So today we have Dr. Cindy Miles. She is a PT and a PhD. She is the director at the Cindy Miles Whitehall Clinic with St. Luke's now. She was in private practice for how many years?
38.
38 years. And so she has immense amounts of experience, and she is also the current president of the Academy of Pediatric Physical Therapy. And so, without further ado, I will ask her to start. And I hear a little bit of sound. Where is that coming?
It's probably coming from.
Is that coming from the speaker? Okay, cool.
Yeah, that's the only one I have. Yeah.
I'm going to.
Get us moved to the next slide.
Oh, that's perfectly fine. All right, there you go.
All right, thanks, Steve. Well, first off, I'd like to thank Steve for organizing and St. Luke's for hosting us for here. Hopefully going to share some fun stuff in the next hour or so, and appreciate you all being here. I know you're giving up either some leisure or some work time for sure. Well, that's all good, so I can move that. Thanks.
Yep.
Before I get started, Steve, I always like to acknowledge my staff. I'll just do it from here. Should work. If not, this is your...
It's just very slow.
Okay.
There you go.
Okay. I always like to acknowledge my staff at Cindy Miles & Associates, all the therapists, all the staff members, my family, and my mentors, because I would never be able to do what I do without the support that I have of the entire team. Also the committed family members that we work with on an ongoing basis, and then all the children who vigorously participate in all of our sessions. So as we move forward, I like to start with thinking about evidence-based medicine. As professionals, we're all responsible to practice evidence-based medicine. If you keep in mind, there's 3 pillars to that: relevant research, clinical expertise, which you all bring to the table, and your patient values and perspectives. But the biggest pillar being your patient values and perspectives. We have to keep that in mind, because why we're doing evidence-based medicine is to improve patient outcome. But at the same time, we have to be thinking about the literature. And when we think about the literature, we have to begin to read it with a critical eye, because not everything in the literature is what it seems. I should just say that.
Oh, you're good.
Just because it's in a peer-reviewed journal doesn't mean it's fact. And I think the biggest thing we can take away when we think about evidence-based medicine and thinking about the literature is reading it with a critical eye, because sometimes things aren't always what they seem. And I look at that especially related to this particular diagnosis. This diagnosis has been around since early ancient Greek time through today. If you pick up any article, though, today, it'll tell you that it's the 3rd most prevalent congenital musculoskeletal anomaly. How many of you are treating torticollis? How many of you are treating more children with hip dysplasia and club feet than torticollis? Exactly. But every article right through today is going to tell you it's 3rd after those 2. So the literature has not caught up with this particular diagnosis, and we'll see that as we go through. This diagnosis can be related to skeletal, which could be a bony malformation between the skull and cervical spine. It could be related to neurological, either due to a posterior fossa tumor, an ocular tumor, or perhaps Sanford syndrome. The most common is muscular, and that's what we tend to treat. We do need to be aware of the other 2, as we need to know the differential diagnosis between the skeletal, the neurological, and the muscular. We're going to talk mostly today about the muscular. I think the easiest thing to do when we look at this diagnosis is to define it from a 1912 Latin definition, torque meaning twisted and column meaning neck. It can be related to 3 different areas. The McDonald's classification back in 1969 gave us the SMT, so sternocleidomastoid mastoid tumor group. So that would be a child who has a tumor and also has tightness of the muscle itself. The muscular tightness group, so the child has a muscle tightness, no tumor. And then the posterior, so POST or PT, so your positional tightness, whereas there's a lack of tightness in the SCM, but there's an imbalance of the SCM. But we need to be careful of these, because these guys, I think, can be some of the trickiest. Fortunately for us, some authors are questioning, too, what is the etiology and pathophysiology? Because right now, we don't have a set definition. Again, if you pick up any article today, it's going to tell you it's related to birth trauma, difficult delivery, or a venous compression of the neck. Fortunately for us, some of the authors are questioning that. If you look at an MRI, the MRI signals are not at all the same as a compartment syndrome. Any of you work with sports injuries, an individual has a compartment syndrome, young lady gets hit with a hockey puck, doesn't have her shin guards on, you're going to see instant swelling, instant contusion, changes in the ectomosis. You're going to get bruising of the muscle to the point with the swelling you may have to do surgery. We do not see that when we're working with a child with torticollis. If you did an MRI, the singles are not the same. Same thing when you're looking at birth trauma. There's no tearing of the muscle itself, which you'll read in an article, the bit tearing due to the birth trauma. It doesn't happen. More than likely, it's due to an intrauterine or perinatal intrauterine constraint. If we look at an ultrasound of the muscle itself, a typical SCM is long and thin and has the same texture as the muscles surrounding it. A baby who has torticollis, you're going to see a thickening of the SCM itself and a change in the echo texture within itself. If you look at this as a typical SCM, here you have a child with torticollis. You're going to see these changes in the muscle physiology about the lower 1/3 of the sternal portion. If you see changes along the entire sternal portion or the clitoral portion, that baby's in for a long ride. It's going to take a long time to be able to treat this baby. If we look at the literature, one of the prognostic factors of treating a baby for a longer period of time, or perhaps a baby that will go on to have surgery, would be a deficit in cervical rotation of more than 15 degrees. Babies that have a cervical rotation of 30 degrees or more, 98% of them will have changes in their muscle tissue. Although babies that don't have any rotation deficit at all, so perhaps those positional tightness babies, 25% of them have changes in the muscle physiology. I think that an ultrasound going forward is probably going to be one of the best tools we have for this particular diagnosis. I personally ask for an ultrasound to referring physicians if I see an SMT tumor or if the child comes in after 6 months. It's a wonderful prognostic tool. I think it's going to give us a better scientific approach to the referral timing, the treatment, and the discharging of these particular babies. Ultrasound is safe. The baby doesn't need to be sedated. There's no radiation exposure, and you're getting real-time information from an ultrasound. Several of the authors that went back to dispute the fact that it is related to birth trauma looked at it and said there could be an anomaly in the muscleblastoma itself. It's static during gestation, but environmental changes then cause that muscle to differentiate and take on characteristics that we just saw, the thickening of the muscle and the change in the ecotexture. If we think about this particular muscle, the SCM, the scalenes, and the trap are all muscles of inspiration. That pulling on the muscle, the stretching and the relaxation of the muscle will cause that muscle to differentiate and take on characteristics. Both sides would be the same. If you have a baby who's constrained and intrauterine and the muscle itself is in an appropriate alignment, and we all know that muscles work in the appropriate alignment that Mother Nature gave us to put them in. If that muscle is out of alignment due to being constrained, it's not going to take on those, not going to allow itself to stretch and relax as so. Plus also when the baby comes home from the hospital, the majority of our babies are born in physiological flexion. We take those babies, years ago we took the babies, put them in the prone position, and the baby had to turn its head consistently to clear its airway. Therefore, if it had any characteristics at all that could, an anomaly in the muscle itself, it would have worked it out. So 40 years ago, 35 years ago, I was treating 1 or 2 torticollis babies a year. Now we bring our babies home from the hospital. We put them in the supine position. The baby does not have to turn its head to clear its airway, and it says to gravity, bring it on, and the muscle stays there and doesn't work as appropriately. This, to me, makes more sense than birth trauma or compartment syndrome. And what's the so what for this? Why do we need to know this? Because if we encourage conservative treatment before contraction, we're going to have less comorbidities with these babies. This particular article was done by Shen in 2005. He wanted to look at a predictive model. Who could we predict is going to go on to have torticollis? What he did is an ultrasound in the first 72 hours of typical babies. He based his diagnosis of torticollis purely on changes in the ultrasound, and within that particular study, 4% of his population had torticollis. Now again, you pick up one of those articles today, it's going to tell you that babies, it's 2.3 to 2% of individuals or babies will have torticollis. Ultrasound changes alone showed us there were 4% of his population or his cohort that had it. When he extrapolated all of his variables out, he found that a longer body length, so just 1/4 of an inch or 1 centimeter if you're not metrically challenged as myself, is an 88% increased risk of having torticollis if the baby is anywhere between 19.7 to 20.2 inches long. Facial asymmetry, first birth order, forceps, and birth trauma, but the caveat there being there was a more difficult delivery due to the fact that the baby was in a constrained environment, not the birth trauma causing the torticollis. And again, what's the so what for this? Early conservative treatment works. If we get our hands on these babies much sooner, we're going to decrease comorbidities and less babies will go on to have surgery. This study was done in California, much smaller cohort, 102 babies, Stellwagen looked at. And she looked at different variables, including range of motion. She found, though, that 73% of our infants had one or more asymmetries. Makes sense. Coming through the birth canal, you're going to have asymmetries work themselves out. But 16% of her cohort had torticollis. She based her diagnosis of torticollis based on difference in lateral flexion from one side to the other of just 15 degrees. So that's 16%, certainly not 0.3 to 2%. She said physicians are just not doing a good enough exam. We need to look at passive range of motion into rotation, and we need to look at passive range of motion into lateral flexion, and that's where she's finding the difference. The majority of the times our babies do not have a major difference in rotation at birth. It happens a little bit after. Passive rotation into lateral flexion, though, could be lacking due to the intrauterine constraint. Of those 16% of her babies who had torticollis, the mothers reported that the baby was stuck the last 6 weeks of pregnancy, and they had slightly longer body lengths. So I like when the literature begins to line up. 42% have facial asymmetry, so a longer second stage of labor, causing a forceps delivery. Again, the caveat there being the baby was in a constrained environment. About 50% had a mild cranial asymmetry and 11% had a moderate. Of those 50%, with the mild, they had torticollis, facial asymmetry, and jaw tilt. 13% mandibular asymmetries, 4 cases of torticollis, 2 cases of facial and cranial, again interfering with the breastfeeding, especially babies with torticollis. She came to the conclusion that the true incidence of torticollis is much higher than reported and is due to the complex nature of the SCM itself, not related to trauma. In her particular cohort, it was a smaller cohort, not related to first birth or to male gender. She says infants that are at risk for developing these asymmetries are the babies who have the torticollis or the asymmetrical tendencies. They have deferential plagiocephaly, again caused by the intrauterine constraint, low muscle tone, and inadequate prone time. Again, we brought our babies home from the hospital. We placed them into the prone position. They learned to work these asymmetries out. Now we're bringing them home from the hospital. We place them on their backs, and gravity says, bring it on. When we put our babies into those prone positions, we encourage that rotation, the lifting and the strengthening and the stretching of the neck muscles independently. This particular diagnosis can present itself as mild, moderate, or severe. And for sure, it is does not affect just the head and neck. It affects the entire child. It affects their visual tracking, their awareness of their upper extremity, the involved upper extremity, sensory awareness of the entire involved side, increased lateral flexion of the tight side, motor development, posture control, midline development. There's a vestibular component. Babies cannot have their head tilted for any length of time and not have a vestibular component, and certainly not have a visual component. It is affecting their weight bearing, their weight shifting, and for sure their head shift, their head shape. And it's affecting the head shape dramatically. We can see that when it presents itself as brachycephaly or plagiocephaly. This particular one, this baby has asymmetrical brachycephaly. But it also presents itself right down from the neck, right down to the lower extremity. I have actually seen a correlation of babies with torticollis and toe walking. And how many of you are seeing more toe walking? Lots of us are treating more toe walking. I think that what we've done is we've biased our babies towards extension, and we've allowed them to go through extension throughout the entire lower extremity and upper extremity. As I said, it doesn't just involve the head and neck. You'll see that it involves the baby right down through the lower extremity, which can include an increase in toe walking itself. One of the things I did when I got my PhD for my dissertation, I looked at risk factors for torticollis. One of the questions I asked, when did you notice that the baby had torticollis? So this was from the parents. You will see that a majority of our parents noticed it at birth, 1 to 4 weeks, or 5 to 8 weeks. Yet the diagnosis of this particular of torticollis was not made until greater than 12 weeks. The majority of the babies that were noticed at birth by the parents were not diagnosed by the physician or the referring physician. And what that is now, it's an impact on our baby's development. But what has caused these factors? You heard me say, I think there's a relationship to back to sleep. Back to sleep is not causing torticollis. Back to sleep is causing changes in our environment and changes in our parents' behavior. Prior to 1992, when back to sleep came into vogue, was the back or the side, about 70% of infants in America were sleeping on their bellies. Our plagiocephaly rates at that time were 1 out of 300. In 1997, when we intensified the campaign for back to sleep, 10% of our babies were sleeping in the prone position. And Torticollis went up to at least 1 out of 250 or 1 out of 6, according to literature today, but the plagiocephaly increased to 1 out of 60. We have a dramatic increase in supine positioning, positional preference, the incidence of SCM dysfunction, positional torticollis, and deferential plagiocephaly that's related to the change in the environments that our babies are placed into. Our babies are spending extraordinary time in the supine position. Our parents hear back, SIDS, death. They do not hear prone or belly to sleep. Back in 1997, when I heard about the intensification of back to sleep, most of us realized there wasn't the internet back then, so we didn't hear about this maybe in 1992. By 1997, I certainly heard about the intensification. By 1999, I started to get 3, 4, 5 torticollis babies on a continuous basis, and I stepped back and said, what is the difference here? Is it related to back to sleep? I put together a PowerPoint and went to every single pediatrician in Lehigh Valley and said, let me help you out here. Parents hear SIDS, death, back. They're fearful. We've put major fear into our parents. They don't hear belly to play. Put the babies on their belly and we'll be done with this. Well, this is 2018. I teach this 2-day course on this around the country. And our referrals at our practice are at least, every one of us are carrying at least 8 to 10 on our caseloads at any one time. So we have made a major impact on a change in our parents' behavior due to more environmental changes, not necessarily back to sleep. Our parents are limiting the positions our babies are put into. And there's also a correlation at the same time that back to sleep came into play, we had this increase of seated and positional devices. We all see that our parents are carrying their babies in those containers, as I call them. They carry them through the mall. Now, we've done a great job of increasing referrals for orthopedic friends. Our moms are coming home with back pain, Dayquil, shoulder pain. Right. It's all due to the fact that orthopedic people love us, right? But they carry those infants around in that extra 7 pounds. We did a study back in 2010, and we asked providers, we asked parents, and we went on the website to look. Out of the parents and the providers, 80% knew about back to sleep. 55% of our babies were given information about awake positioning, which meant 45% of our parents had no information at all about what to do with the baby when they're awake. And only 15% were given information on to put them into the prone position. If a parent had to choose, they always chose supine. So again, so what? We've made so many environmental changes for our parents, and we put fear into our parents. If we look at prone, the baby, when they're placed in prone, they practice moving their head from side to side. As I said, they clear their airway. They're looking for visual input. If we place them into the prone position, they learn to contend with gravity from their experience, and they practice to control against gravity. They increase their strength and they increase their symmetry. They're allowing their muscles to work against gravity with natural elongation. So again, when we brought our babies home from the hospital and we placed them into that physiological flexion, what we allowed them to do was work against gravity slowly. So we work to turn on these extensor muscles slowly and quietly. We know that these extensor muscles fire so much faster than our core muscles. Now we take our babies and we place them in the supine position, and we're turning on these extensor muscles, and they're firing so fast. Again, we've biased our babies towards extension. When the parents ask you, I don't understand, they love to jump, they love to push back, because we've turned these muscles on, and we're not working our core muscles through here, and not allowing them to work slowly and with the natural elongation against gravity. We're also, one of the problems is, though, our parents do not hear prone. They do not hear belly time, as I said earlier. But then you have to ask yourself, how much time in prone is enough and where is enough? We have to tell our parents where to put them. I had one child several years ago that I couldn't understand why over a 4-week period why she wasn't changing. And the mom said, Cindy, I put her in prone. I put her on her belly all the time. Every time we go into the bedroom, I place her on her belly on the bed. Well, you can't place the baby on the belly on the bed. They have to be on a surface where they're going to get a ground reaction force to be able to work on the strength of their upper extremities, work on their head control, learning that chin tuck, getting that SCM to come in and work appropriately. So we have to put them in prone positions, but they have to be supervised for sure. Do we need help with this diagnosis? I think we do need help with this particular diagnosis. This is probably one of the best health policy changes that we've had. It's probably made the most impact. We have decreased SIDS by over 50%. It is a fantastic health policy change. We don't get any better than that. 50% is fantastic. But since that Back to Sleep campaign, though, we've seen a consequence of musculoskeletal, including torticollis and plagiocephaly. We've seen a change in motor development, which has affected the baby's motor outcome. If you go back and you look at the literature from the American Academy of Pediatrics, they will say, yes, we've had an increase in deferential plagiocephaly. We have delays in gross motor. We just need to increase awareness of prone play. We need to alter the supine hip position and avoid that time on the car seats. But yet only 15% of our parents are being told what to do in the prone position. And if you ask the providers why not, they say, we don't understand prone. We understand back to sleep. And we can get it done easy and fast, and we can tell our parents, we don't understand prone. We don't know the liability, the risk, so we just avoid it, which makes sense if you're talking 15% of our parents are given information on that. If you go back and look at the articles in 2011 when they changed from the Back to Sleep campaign to the Safe to Sleep campaign, they are still not talking that torticollis is related to this change in our health policy or the change in our environments. They're still talking deferential plagiocephaly, and they're still talking about changes in our development. They also tell parents that 2 to 4 weeks after birth, when the baby is awake and supervised, place them in the prone position, maybe 30 to 60 minutes a day. 2 to 4 weeks after birth, that baby says, no way. They've had gravity just letting them hang out here for 4 weeks, and they're saying, you're going to put me in that position where I have to work? I like when gravity just lets me here. They also tell us to minimize the amount of time in the car seats, but yet if a baby has reflux, which a lot of our babies now have reflux, they're told to place them into the car seats and let them be there for at least 30 minutes after they eat. How many times per day are that baby being put into the car seat? And certainly we need to monitor their head change. What we don't think about, first thing I thought about in 1997 when I heard about Back to Sleep, I thought, oh my, our babies are not going to develop head control and their scapula is going to fall off of their trunk. And that's exactly what happens. We are treating these 6- and 7-year-old young people that are coming in with their scapulas falling off of their trunk. Certainly long-term effects have been on shoulder and posture. In addition, what we've seen is an increase in oral motor. When you think again about that baby coming home from the hospital and being placed into that prone position and consistently turning their head to clear their airway, think about the rich sensory input that they were getting to that face, to that mouth area. You ask yourself, why are speech therapists more in demand than physical and occupational therapists? It's due to the fact that they are not getting that beautiful sensory input that they used to get before. We have feeding issues. We have feeding therapy groups. Our babies are not transitioning from mushy foods to solid foods. They are not placing their hands in your... How many of the parents say, my baby doesn't put their hands in their mouth. Isn't that wonderful? They don't put the toys... No, that's not wonderful. Your mouth is a third hand. You need that sensory input to the mouth to be able to move on to different textures in food and to also to be able to move on and have better speech and language. We've certainly changed our history form over the past 10 years to ask the question, were you ever treated for torticollis? And especially when they're coming in for speech and language. The jaw is retracted on the tight side, and the tongue will deviate to the long side. It's causing a problem with babies latching on. One of the things I did was talk to my controls about breastfeeding or bottle feeding, and what I heard more often than not, that they were breastfed, they were using the breast milk in the bottle because the baby wouldn't latch on. Which makes sense. If you have that, all we need to do is get there in the beginning, just a little bit of jaw control forward, maybe a little bit of tongue mobilization, and we can help our parents to be able to breastfeed more efficiently and not have to switch to that bottle feeding. We have to ask ourselves, if we continue to have the posture development problems that we have, will future generations be able to defy gravity like this, and will we enjoy play like this? Or will we have to settle for play like this in baseball? And more importantly, in football. I hope not. I think that as pediatric healthcare professionals, we need to be more efficient about informing our parents about the importance of varying their baby's play and their positioning, but we also have to reinforce the Safe to Sleep campaign. There's good efficacy for that. We're not going back to prone. We've saved a lot of babies. We just have to figure out how to get rid of all the consequences of that and help our parents change their environments. When we think about intervention, I think our job is to make it fun for the child. We have to add variability and complexity to their movement patterns. We can do that through small movements so we can improve postural control and their postural skills. We need to work on balance, not only balance in standing or in hands and knees, balance between one side to the other. We need to consider dosing. How often should we see these babies? Should we see these babies once a week, twice a week, 3 times a week? We have to make good consideration on dosing, especially with changes in our payment systems that are coming down the pike. We need to work on upper extremity weight bearing, scapular stabilization, midline stabilization, active extension with symmetry. And we can do that through lots of ways, through the aquatics. Make sure that we're always playing with age-appropriate toys and looking for appropriate activity for our parents to engage in, because our parents are the key and home exercise is the key. In addition to change in our posture, I said earlier we certainly have had a change in head shape. If you look through the literature, you'll see it discussed as deferential plagiocephaly or DP. I put that in bold because more than likely in literature we're seeing this more often than not. But you'll also see positional plagiocephaly, plagiocephaly without stenosis, non-stenotic plagiocephaly, so DP, PP, PWS, or NSP. Or you might even see it stated as flat head syndrome. The literature now is telling us that because of lack of consistent in terminology, we don't really know the true incidence of plagiocephaly, but it's estimated to be anywhere from 46 to 48% of our newborns, and perhaps 56% of all multiples. It's been a dramatic change in our baby's head shape. This is how a typical baby's head should look. This is a baby with significant brachycephaly. If we look at the tortal site, or Dr. Jane Scott is a neonatologist who developed an item called the tortal. She says that 100% of all of our babies are at risk for developing plagiocephaly or brachycephaly, and it certainly makes sense. Our babies are on plywood 24/7. Those car seats look great. The little pack and plays look great. We know that we cannot buy a mattress that's soft. It's a hard mattress, which is great. So again, we are saving lots of babies, but our babies are on plywood 24/7. Your arm is a ground reaction force. If you're holding that baby and you're holding them in the position on your arm with their head down, that's supine, and you are a ground reaction force. Understandably, why 100% of our babies are at risk for plagiocephaly. Why doesn't it resolve? Well, we have increased torticollis. We're limiting our positions. Our babies are in supine mostly day and night. They're in containers. We've changed the mattress and the bedding since we changed to the Safe to Sleep campaign. They're in decreased prone. There are lifestyle changes. Our parents have lifestyle changes. There's less time for them to reposition the infants. Infants are rolling earlier. More are rolling supine. There's spending more time in supine before they can reposition themselves into prone. This diagnosis is pure physics. It totally makes sense. It's pure physics. We can understand why it's not resolving both the head and the torticollis in and of itself. There's been an increased risk in multiple births. In the last 3 decades, the twin birth rate has risen 76%. That means less intrauterine space for these babies, and more times than not, multiples are born preterm, and more preterm babies are surviving. Therefore, their skull is more fragile and susceptible to deformation. Bone stiffness will increase 5 to 10 times the last 10 weeks of gestation. We don't know, though, what happens after the babies are born preterm. Does there a change in that bone stiffness? Does it accelerate? Certainly makes sense, though, why our preterm babies, their skull is more vulnerable to deformation. Though, we can certainly be a part of this. We can help this. If we can talk to our caregivers about infant positioning either prior to birth, just after birth, we can help to decrease deferential plagiocephaly. It really is a matter of education and educating our caregivers very early on, especially maybe for sure during pregnancy, right after delivery, and at least then the first few months of after delivery. As far as long-term outcomes for babies who have plagiocephaly or brachycephaly, there certainly has been an association between cognitive delay and motor delay. We don't have a causal relationship at this point, but there are certainly relationship to both cognitive and motor. So I challenge all of us, who will be your next case study to see really what is the cause of that, what is the incidence of that. To me, there is no question that we would not have a change in motor or cognitive delay if you take the baby's skull base and you turn it around. This is a typical baby skull base. This is the amount of protection that Mother Nature gave our babies. A baby with plagiocephaly has lost that protection. A baby with brachycephaly has lost that protection. You tend to look at that and you say, gee, what other diagnosis do we have right now that has increased? Concussions, We are getting great at diagnosing concussions. We are getting great at admitting that more of our athletes are having concussions. But wouldn't it be a great study to step back and say, do we have this increase in concussions because of the change in our baby's head shape? I have contacted the Academy of Sports. I've contacted Neuro Academy in addition to our own Pediatric Physical Therapy Academy to say, let's do a retrospective and prospective study to look at this. As how many of our children perhaps are having these concussions based on their head shape, and can we change that? Can we come up with better helmets? Or more importantly, can we stop this from happening? Or if they do have this, we can prevent this just by talking about positioning with our parents. If our baby's head starts to change, we can correct it by putting our babies into helmets. There's a lot of controversy on helmets. If you ask me, though, helmets work. They get the job done better and faster. The most ideal time to put a baby in a helmet is anywhere between 4 and 7 months. A lot of our physicians are not referring for helmet, and many people will tell you it's cosmetic. I hope I just convinced you that it's not cosmetic, but if it is cosmetic, so what? We live in a society that bases value on cosmesis, on looks. But even if you didn't think about looks, what if they can't fit into a sports helmet? What if they can't wear glasses? And more importantly, they have no choice. You can tell parents that if you don't put braces on their teeth when they're 14, when they're 24, 34, 64, your child can put braces on their teeth. If you don't put a helmet on your child before 18 months, they have no choice. So if you are satisfied with the way your baby's head looks, then go for it. But your baby may not be able to wear a helmet. And just consider if this individual did not have a helmet that fit. What outcome are we looking for with our babies when we're done with treatment? We're looking for full, passive, and active range of motion, symmetry between bilateral neck, trunk, and extremity, active midline control in all positions, strength of their bilateral neck, trunk, and extremities, symmetrical righting and equilibrium reactions, age-appropriate development, and facial symmetry. Our goal in therapy is to promote the optimal level of movement variability. One of the things I think that we need to do that many of us are missing the mark on is bringing our babies back. I tend to bring the babies back. I tell parents, you're going to see me till your child graduates from college, or perhaps even when they have their firstborn child. You need to check in with me at least once a year. I feel that as physical therapists, pediatric especially, we are the PCPs of exercise and we are the PCPs of development. But when we look back at this diagnosis, this is a great study done by Oman. She looked at 58 children who had already been treated for torticollis as infants. Small cohort, I get that. She brought them back between 3.5 to 5 years of age, with the mean age being about 4, a little over 4. She looked at their passive range of motion and decided that the baby loses about 10 degrees. A typical range of motion for a baby at birth is about 110 degrees, 100 to 120, 110 being average. Lateral flexion about 70 degrees is average. By the time they're preschool, they've lost about 10 degrees, so we're talking 100. I gotta love the way that she checked her range of motion, 100.1 and 68.5. Pretty thorough. But she found that within her cohort, 74% of them had symmetrical passive range of motion into neck rotation, 88% passive range of motion in good shape into lateral flexion. But also what she found is 26% had asymmetric passive range of motion into rotation and or lateral flexion. 45% of them had some degree of muscle imbalance from one side to the other. So much so that one of them had a moderate, not even extensive, moderate decrease in passive range of motion. They went on to have surgery. That particular parent, if you asked them, they said they did not notice the increase in the head tilt. Our parents are a wonderful resource, but the literature drives us to tell us that parents don't notice when the baby's head is tilting. Those pictures I showed you of severe, that mom will tell me to this day, that little boy is 10, I never saw that amount of tilt on him, and he was significantly severe. Parents are a great resource, but it's their beautiful, fantastic little baby, and that's going to be perfect to them, and it's not going to have these asymmetrical patterns, right? Within this cohort, though, what we found is that 45%, almost half of our cohort, had some degree of muscle imbalance imbalance of the neck lateral flexors. The baby's head tilt, the risk factor for having a head tilt, was not related to the passive range of motion. It was related to the muscle imbalance from one side to the other. So that's why I say when we're working on balance, we need to be thinking about balance of the entire body, right down from the neck down to the feet, that everything's working in balance within itself, but especially at the neck itself. Then a baby who had asymmetrical passive range of motion, so different than this imbalance in the muscle, their risk factor was based on the lack of range of motion at birth, which again, that's one of the prognostic factors that tell us the baby's going to go on to have a harder time with treatment. They're at a higher risk for surgery and a higher risk for a poor outcome. This surprised me, female gender. And then there was an increased trend in birth weight and later week gestation. But this is the most important, to be thinking about that muscle imbalance. We are letting our babies discharge too soon. We need to monitor and bring them back. If we discharge them before they are 12 months of age, we should always bring them back when they're walking independently. So anywhere from 12 to 15 months. And then at least 6 months later for that emergence of that ballistic movement. And certainly if the baby falls higher on the growth chart, at 80 to 90% in weight and height, or they're hypotonic, lower tone, we should be bringing them back more often. You want to provide them with a list of future skill acquisitions. Certainly want to monitor their age appropriate. But right here, we should recall and reevaluate every 12 months, so at least till they go to college. And as I said earlier, perhaps their firstborn. And some of these little guys are the reason I think that. This little boy, we treated him up to 14 months. He moved to Texas when he was 15 months and came in for a visit. I checked in with the parent just a couple months ago, and I asked her to send me pictures. If you would have asked me any child on my caseload that would need to come back that would have a problem later on, he'd have never came to mind. I'd have told you I am not a gambler, but I'd have said to you, I'll give you $1,000 that it is not this baby. This little boy, here he's 5. I contacted her, asked for the picture. She said she was actually just taking him for an occupational therapy eval. She sent me the results of the eval. He needed OT at least twice a week. He was having trouble using both sides of his body. He was having trouble with vision. He had facial asymmetry. This little boy did not have facial asymmetry when I treated him. When he left at 15 months, he looked great. This would not have been a baby. His entire body, he is not using it the same. You see lateral flexion right down through. This young lady, we discharged her at about 5.5. At that point, I had started to keep in touch with parents. I kept in touch with her. Life got in the way. She was a set of twins. Mom is a professional. There's another baby came along. Please send me pictures. I did get pictures periodically. One of the last pictures I got was when she was 8. I called her up. I emailed her, said, please bring Corey back. Look at her. She's head tilt, and now she's getting facial asymmetry. Continued to be persistent with her. She came in this past spring. She is now 10. Look at the muscle banding that she has. She's in a consistent head tilt. You can see on both of these pictures the glasses are not fitting, and she has facial asymmetry. I sent her for x-rays. I sent her to the physician. Mom just sent me an email saying that she was diagnosed with juvenile scoliosis, 20% thoracic, 16% lumbar. Holy geez, we were all shocked, was Mom's response. We need to bring these babies. Again, Corey was in great shape, but I did want to check in with Corey. If we don't check in with him, my biggest fear is the amount of facial asymmetry that returns. If we discharge them before we take care of this facial asymmetry, they're going to come back. And even if they don't have facial asymmetry, you can see from those 2 cases, they're going to come back. And the only way we get to this is through the tissue. So it's the tissue on the site of the torticollis, not on the side of the plagiocephaly. The head is deformation on the side of the plagiocephaly. Again, pure physics. Baby lays in the supine position or any position. They turn their head to one side. The back of the head, the skull starts to form. The ear goes forward. The forehead goes forward. That's deformation. Or they lay on their back all the time. They're lower tone. They're not moving. That's brachycephaly. The facial asymmetry comes on the side of the muscle tightness on the torticollis side. So some of the requests that I would have for some of our referring physicians, and then even for all of us, I think that they need to refer to PT on the first sign of asymmetry, either range of motion or skull deformities. We can also think about that predictive model. If the baby has a longer body length, the mom reports that the baby was stuck the last few weeks of pregnancy, and is there a difference in range of motion to lateral flexion from one side to the other? Why not start to use that predictive model that our physicians could be looking at that and refer them to us immediately? Conservative treatment works. The sooner we get our hands on the babies, the less comorbidities they're going to have. How about an ultrasound prior to treatment and then at discharge? Let's look at that tissue. Maybe had I done an ultrasound on my little Sebastian, maybe there were still changes in that muscle tissue itself, and we'd have seen that. I think an ultrasound is going to be a fantastic prognostic, diagnostic tool, and we can look at this particular diagnosis in a more scientific way. The literature and research has not kept up with the change in the presentation of torticollis. That's why I like to call it the changing faces of torticollis. I think that PTs or OTs should be screening all newborns. Why not? We're the PCPs of development. Why not? We should be doing yearly screens, and we need to educate our parents prior to birth or shortly thereafter. Excuse me. I used to be grumpy about this particular diagnosis because I know that I was only treating those 1 or 2 babies a year. And I thought to myself, we can go back. We can return to this. Why? Why not, right? But I came to the conclusion, I am definitely an optimist. Optimists are wrong as often as pessimists, but we have more fun. But I'm also a realist. There have been too many changes in our environment. We're not going back. There's great efficacy for back to sleep. And then all the other changes add up. We're not going back. I think we can decrease the impact that we're having on our healthcare system. I think we can decrease the impact we're having on our babies' development and our families. But I also came to the conclusion that torticollis is a gift. We are able to get our hands on these babies right from the beginning. Those of us that are in the NICU, those of us that are getting babies from the NICU, those 32-weekers, 36-weekers coming in, we can not only treat them for the torticollis, we can prevent the plagiocephaly, but we can also detect other minor problems that may be happening and maybe head them off at the pass. So to me right now, I think that torticollis is a gift. So I'm not as grumpy. I think we can decrease the impact. I think we can see these babies much sooner, but I'm not as grumpy. So I certainly have hope for the future that we can make a change and really impact our families' lives. I think that our final goal for all children is maximal functional independence across the lifespan, and they can have that if they consistently check in with us. And I hope that we continue to be wowed with play like this as we watch our sports on our TV on a Saturday or a Sunday morning, right? So are there any questions? I know that was quick. This is a 2-day course that I put into less than an hour because I knew we had some, and I know that the slides weren't great because we just didn't play nice between the Mac and the PC. If somebody, I did make a copy of the handouts for Steve that are better, that you can have a copy of that. But one of the things I ask you is never underestimate anyone. Every child we can take to great heights, and that's our job as pediatric providers. So thank you. Any questions?
Are you involved with our own NICU?
I am not. So we just came on to St. Luke's in January. So although physical therapy at St. Luke's really is mostly about outpatient, it's not about inpatient, it's certainly something is a goal of mine to be able to start to meet all the different docs in the system and then get into the NICU and that stuff.
Just stand behind here because they can't hear you.
The question was, are we involved in the NICU? And I said, at this point, physical therapy at St. Luke's is really only involved in outpatient, but certainly would be a goal for us to be able to get in and have a conversation with the NICU nurses and also with the physical and occupational therapists that are in the NICU. I actually, after Steve sent this out, I was contacted by a group of nurses that asked. They said they can't make it today because of the rounds, but they asked that I can come. I don't think they were NICU nurses, but certainly the more education we can get to any of our referral sources, we can help to decrease this. Any other questions? Well, thank you for coming.
Is there anybody online? Any questions online?
Oh.
In an ideal world, do you think that the yearly screens are frequent enough?
Well, I think it depends on a baby size again. If that baby is hypotonic, if they had more of a difficult beginning, or again, they're on the chart, either at the higher end of weight and or height, then I think we need to see them more frequently. And certainly with the age of technology that we have, if you're worried about that baby in between, go ahead and ask the parents to send you pictures. I can tell you at this point now, when a baby's walking out the door, February 2nd, okay, you come February 3rd, works for you next year? Okay, I've got about 8 or 9 kids on my caseload already for next year. So I'm scheduling them just like you would the dentist or the gynecologist. Why not? But I do think a yearly screen is a start, but certainly if you see any other problems, I'd be bringing them back more than that. But have the parents send you pictures.
If you see them a year later, another year later, another year later, and everything looks great, is there still a need to keep seeing them through having their first child?
Why not?
I mean, why not? But
yeah, I mean, we can help them with, I mean, one thing to even think about, one thing is to get the parents to buy in. You want your child to play sports? I can help you with sports. augmented development comes from exercise, and that's us. We can give them. I had a young boy that came in that I really did treat. He was treated by one of my colleagues, but I brought him back because I needed to look at some other things for my presentations. Mom brought him in. This young man was severely hypotonic as an infant, but he's playing baseball, he's playing football, and he's playing basketball. But his posture was awful. So the conversations I had with him, hey, if we work on these exercises, you're going to be able to increase the speed of your pitch. So why not? Steve.
So one question I have is, if you're asking people to come in annually, and it does take a lot of, people are busy, how long does the screen take?
I schedule them for an hour, just like any typical
Okay.
evaluation. So I don't know if you're familiar or not, but the APTA came up with an annual checkup for adult population, and we just produced one, an annual checkup for infants and children. So it is, if you're a member of the APTA and a member of the Academy, it is on our website. It's available. And actually, myself and a couple other people will be doing a webinar on annual checkups for children in November. So it's just something we reproduce.
I'd like to discuss that more with you, maybe offline, just so it doesn't take everybody's time.
Sure.
Because the APTA one that they produced is extremely long and arduous.
For adults,
for adults,
yeah.
at least.
I haven't looked at theirs fully, but ours I think is doable within an hour screen. Yeah, but I do bring our babies back for an hour because you have a conversation with the parents, you ask how they're doing, that they might need a few exercises to tweak for sports, or you may have to set up a time to bring them back a couple times after that. A couple of the kids I brought back, you do episodes of care, and boom, you set them up again for next year. Those are usually when they're younger, as they're coming back older. But look at Corey. Corey's now having to come back. And hopefully not surgery. Any other questions? Well, thank you.
All right. Thank you very much. Please make sure. Please make sure you sign out if you're from New Jersey, and please make sure if you're online that you email me for your quiz. Thank you very much.